So to introduce myself, my name is Kasiram. I'm a professor of social work at a university, the University of KwaZulu-Natal, on the east coast of South Africa. What motivated this topic? It actually began several years ago with my interest in research with HIV positive women, the helplessness and hopelessness that these women feel, but also something that they often said to me, and that was, when we feel this hopeless, we wonder whether we've been let down by God, whether we've been punished by God, and they begin to question who they are, where they come from, and the meaning of life. That was one aspect of the motivation to the study. The second aspect was my own personal experience of a dreaded disease, cancer. I was diagnosed in 2012, and I was extremely touched by the sense of humanity, the sense of connection I felt to people who I hardly knew, that wanted to do good by me, to offer me all kinds of help. And this told me something, that maybe I need to examine this a little bit, this whole phenomenon of the connection of the human spirit a little bit more. The third aspect to the study is about my work and relationship with a colleague in the UK, Penny Satori, who actually looked at studying the near-death experiences of patients. I've, for convenience sake, titled this near-death experience as a total topic, because to my mind, when people are confronted by a dreaded disease such as the one I'm going to refer to, and that is HIV, there is this experience of why me, where now, what do I do? And the commonality with the experiences of patients who actually had near death on the operating table, for example, told me this is something to talk about. And it's an early examination of the topic. By no means, I'm not going to make claims to any finality, any conclusions that I can categorically say, this is what near-death experience is all about. So you'll bear with me. So I gave you an idea of this paper being based on two studies. The one was based in the UK with patients who actually had near-death experiences, and my own study with HIV positive women back in South Africa. So, study one on near-death experience was motivated by Penny Satori's actual experience in intensive care with a patient who had a near-death experience. And she thought, wow, this needs further examination. She is now, Penny Satori is a well-known author, a radio speaker. She has her own web program. She does interactive counseling, and I look up to her because I believe that she has so much to offer on an area that many of us shy away from because it is awkward, uncomfortable, not something within the clinical repertoire that we usually comfortable with. And then, of course, my own study with HIV positive women. I run a family therapy clinic at the university, and every second person that came to this clinic where my postgrad students offered therapy was HIV positive. You know that back home in South Africa, the HIV positive rate is extremely high. And this said something to me that maybe I need to look at what makes these women tick. How come they go on? What is it about the hopelessness that finally translates to wanting to look at a future of positive living. What does it take? And so that prompted my study. The research methodology was, in the case of study 1, a mixed methodology study, where Penny began with 300 intensive care patients and then finally did a qualitative study with 15 of the near-death experience patients. In my own study, it was purely qualitative with the women that we saw at the family therapy clinic, and out of the women we selected 7 and used a narrative framework, something that Sophia mentioned earlier. So let's look at what study 1 offered to us. Penny looked at 5 years of data collection with her 15 patients. 7 of the near-death experiences occurred during cardiac arrest, when there should have been no possibility of any conscious experience. Her patients reported heightened awareness that was beyond any human experience. However, because most of her patients died, post this experience, she was only able to follow up with 2 of these patients, 2 of the 7. She goes on to say that retrospective studies, like for instance the old ones by Moody and Ring, show that near-death experience seems to have a profound impact on a person's life. The 2 patients that she followed up showed similarly that experience shaped how they thought and how they continued to live. Unfortunately, of course, near-death experience is underreported. Patients themselves don't understand them, neither do healthcare professionals provide support in understanding them. Let us look at exactly what her findings were. I'll start off with the general comments. The writing in red shows that there is an overlap between her study with patients who actually had near-death experience and my study of HIV-positive women who were confronted with death and debility. First of all, with her study, there was no fear of death amongst the patients who experienced near-death experience themselves. When they were confronted with whatever it was, however they described it, for example, the meeting of some sort of light at the end of a tunnel, they felt that this experience offered them inner strength. Hence, there was no fear of the actual death. There was heightened reliance on their own intuition because their experience was so intense that experience was their best teacher. With both our studies, both the patients and the HIV-positive women, the experience helped them appreciate life more. There was also in both the studies a change of values, which in Penny's study, the one with the near-death experience, was so drastic. For example, it even brought about divorce amongst a couple of the relationships, because people began attach different meanings to their life. And so when people don't see eye to eye under extreme circumstances, it's going to produce divorce. What else? In both our studies, our patients became more loving, tolerant, and compassionate. And there was a desire to serve other people. And this is something that I experienced also during my treatment with cancer as well, that there is this heightened awareness of the gift of life, and you want to make good, you want to be of service to others who are experiencing similar circumstances. So let us look at some of the themes that emerge from study 1, and some of this is repetition, so I'll try and fly through that. The no fear of death I've mentioned. The difficulty in communicating the actual near-death experience to others. And that is why there is a need for healthcare professionals to begin to interrogate this, to begin to recognize that this is a need, and to help patients to express what they experienced, what it means to them, and how they could make changes to their life based on what they experienced. So confusing was the experience that some of them even thought that they were going insane. Change of values I've mentioned, as I did a greater concern for others. Relationships, I've alluded to that, where this is still study 1 with the near-death experience. They became more loving to others, and I mentioned this earlier in relation to the compassion that was experienced. Let me move over to this particular point, the realization of the interconnectivity between everyone. This point merits a little bit more elaboration. Here's why. When you are suddenly experiencing a traumatic event, and when you get support from sources that you didn't even know existed, you almost feel that there is a higher intelligence at work here. And this is what I believe I experienced personally as well. And this is why I wanted to say more on this, because it relates to something that was said earlier in the presentation at 12:30 about subliminal therapy. And I asked the question whether it wasn't even connected to some form of spirituality, this higher intelligence. But this interconnectivity is what really amazed me, what patients were talking about, what my women were talking about, that they were not alone. They wanted to. They believed that they were part of a larger body and that they were answerable to this body. In fact, one of my students, who is currently doing her PhD in social work, referred to the need as follows. She said, you can only grow when you give, and you can only give when you connect. And I thought that was extremely profound, because she explained, as an HIV positive woman herself, that unless you begin to look outside of yourself, you're going to only experience gloom and depression. And this is something I think some of you mentioned earlier, like for instance yourself, Sophia, when you spoke about making sense of what you were experiencing, but getting outside of yourself as well. A lot of the people in the near-death experience study drew strength from the inner source that they experienced during this near-death encounter, and they looked at it as a renewal of their relationship with God. And then, of course, this helped with their own inner coping with life. They lived in the moment. They felt that every day was a gift. And I think as a cancer survivor, I felt that at the time, especially when I watched the patients being plugged to the chemotherapy. Fortunately, I didn't need to go that route. And I thought, how do these people look forward to another day? But you know, they each have a story to tell, and they each tell you that this gift of today is what I am living now. This is the present, and it is my gift, my present. And so you are forced to appreciate the moment and live in it. So what do we learn from study 1? That, for instance, near-death experience is a real phenomenon. One needs to recognize it, embrace it, accept it. They have the potential to empower people, and healthcare professionals need to recognize that this is a phenomenon and need to provide support to patients. They have the potential to teach us all without us needing to have to come close to death, if we could engage with what these people are saying. Now let me go on to study 2, and that is the study with HIV positive women. A lot of the women, not a lot, all 7 of my women felt that they were damned or defeated when they were hit by the HIV positive diagnosis. They experienced multiple layers of hurt, but what did this do? Suddenly, they were completely open to a level of support that they didn't experience before. Previously, there was always conditions on which they accepted therapy and support. Here, they were completely laid bare. Something else that both in Penny's study on near-death experience and in my study, what we experienced was this progression from receiving help to now believing that I've been there, done that, now I want to give. Like I explained earlier, what one of my students who is an HIV positive participant in the study, she said, you grow when you give. What my woman also said was that if you really want to open up to the diagnosis, to accepting what is going on, you need a caring atmosphere, a caring and compassionate relationship, a supportive climate, so that you can open up. Even though I said earlier that there is this unprecedented need to want to be available to any and every form of support. I spoke about a need for connection, and I referred to this in the earlier study. Here too, in my study, there was a need for wanting to connect with other women who were HIV positive. And, I've recently read a book by Anita Murjani entitled Dying to Be Me, a woman who, because of her own near-death experience, has spontaneously healed from stage 4 lymphoma. And you are welcome to Google her work. She has several snippets on YouTube, etc. And she has this book out. And I just was amazed at the level of interrogation. She examines exactly what her near-death experience did, and for her it was connection with the human spirit. That her experience while she was that ill helped her see that she is all about love, she is all about humanity. My woman said that if you connected in that way, you will not judge others. And one has to remember this in context, that when you have an HIV positive diagnosis, you are often accused of a whole lot of things, that you've had unsafe sex, that you may be a woman of loose morals, etc., etc. So this judgmentalism is big. Connection also, of course, promotes forgiveness and support. And then using narrative language, women found that in my study that they began to move from a poor me script to a script of I can and I do deserve kindness and forgiveness. That there was this wonderful gratitude experienced for the gift of life, and I've mentioned this earlier in both our studies, but also that life was finite. There was an end to living, and therefore you had to make amends and be present. Let me go to the specifics in the various themes in relation to my study. I'm not going to read it all out because much of this has already been mentioned, but I'd like you just to look at it and I'll comment on a point here and there. The first theme, of course, was with the HIV positive women, how many levels of hurt they were experiencing. Look at the last one there, that they really said, you know, there is a need to grieve, but know that it's got to come to an end and you've got to start living again. And that was significant because it was saying there is need to move on, not to stay in one position only. But something that I also want to bring attention to, and that is the support of community. And I heard earlier mention of the need for grieving and to connect with what is going on, to be aware, but without support, whether it comes from community, government, neighbors, whoever. How do you move on? How do you begin to change hopelessness to hope? Then the theme about positive living had 3 dimensions with my study of HIV positive women: the need for disclosure, the need for empowerment, and the need to eradicate the virgin myth theory. Now, let me just go to that last one. You know, I spoke earlier about judgmentalism. One of the myths prevailing in South Africa is that if you have sex with a virgin, if a male has sex with a virgin, you will cleanse yourself of having AIDS. As a result, you have a lot of child rapes, and this is not to be alarmist. This is actually true, as some of my colleagues, and I see one colleague here from South Africa might agree with. It's sad, and what people were saying is that as far as that is concerned, let's have life skills education. Let's even empower young men so that they don't need to feel like they are less of men because they are not having sex with a virgin. And so life skills to educate, life skills to also change faulty beliefs. Then on the theme of relationships, I spoke earlier about the need for positive relationships, to nurture positive relationships. The second sub-theme here is support prevents isolation, because when you've had a near-death experience, you feel very alone. People began in that study questioning their sanity. When you are HIV positive and you've disclosed your status, you are isolated. Yeah? And when you have cancer, a lot of people feel that they don't want to tell anyone else. And so you tend to get isolated. But if you disclose, you receive support. It's common sense, but it doesn't happen always. The theme of externalization. At some point, my woman said, okay, time for grieving is over. I need to realize, and this is again the narrative's perspective in vogue, I am not AIDS. I am more than AIDS. I am bigger than AIDS. It is just a virus. It is not me. Others, in externalizing being HIV positive or having AIDS, said, oh, it's just a visitor. It can visit any time, but I'll be prepared for it. So looking at it as a problem out there and me as a separate entity, the person is the person and the problem is the problem. But also, again, I refer to the need for government intervention, and our women spoke about this. The government needs to do something. And when you look at the graffiti on the walls in Greece, I think that you are saying very much similar things. I read, and pardon my French here, I was walking up some of the steps going to visit the Acropolis, and one of the little bits of graffiti said, "I don't need sex, the government F's me every day." And I thought, okay, that is saying something. That's real anger at the government, but it's also asking, begging for some action in an angry way. And so with AIDS and the South African government, we have what is called Operation Sukumasahe, which is wage war against the disease. A whole lot of programs initiated by the government for the people, with the people. And that program involves various stakeholders, services, and providers. Of course, a lot of our women, because of being HIV positive, could not hold down a job because they needed to make sure that they took their antiretroviral therapy on time. And so unemployment, poverty, and food insecurity were huge problems that they had to contend with. If you're interested in learning more about this, you're welcome to email me, and I'll slip back to the first slide so that I can send it through to you if and when you ask for it. But this theme spoke about the need for treatment, the need for even part-time. It was like women were begging, please, can they not even offer us part-time employment? They spoke about the current policy where you can only receive treatment if your blood count is at a certain level. And so people, to get money from the government, did not take their treatment because having AIDS was worse than being poor in their eyes. Sad, isn't it? But that's the truth. They would rather die of the illness or have all the opportunistic diseases associated with AIDS than have to bear the burden of being poor, not having a plate of food, and not being able to feed their children. This is what our women were saying. But of course, we live in an economically constrained society, and so the burden on the government is enormous. What do we do about that? Different people were doing different things. Some of our women were looking at food gardens, little gardens in their backyard. They said, you know, I go at a certain time every day, and this introduced a ritual in their lives which helped them live in the present, but also looked forward to the next event when they would, let's say, water their gardens or look at getting the crops to sell from their gardens. And then, of course, earlier I mentioned how this interconnectivity looked at examining women's spirituality, and this is how it was expressed by my women. They said, I have an attitude of gratitude now for life. I know that I can do something with the rest of my life, even if it means to take care of my children in whatever way I can. Sadly, they also accepted that this is God's will. They believed in God's supremacy, and of course, I mentioned earlier, thank God for another day. How did they express their spirituality? Yes, they prayed, they read scriptures, but also engaging with nature, taking walks, just going outside and outdoors, because then they felt This was something that they couldn't control, but was God-given. And so they connected with their spirituality in that way. They lamented that spiritual support was not forthcoming from health professionals, and they wished that that would happen more. So learnings from my study is the shift to openness motivates action. In other words, when they're desperate and debilitated and damned, they are open to wanting help. The need to use the narrative in rewriting positive life scripts. That receiving help at some point evolves to giving. And this you can use, especially the social workers amongst you, can use in becoming a citizen therapist, where you are offering help to others. And this work is prompted by a South American, Rojano. I'll give you the reference later. That professionals do need to engage spiritually rather than run away from that. Reignite simple pleasures, a walk. Therapy doesn't always need to be grandiose, something that's difficult to understand. Simple things also help. Appreciation of the fragility of life. Live, be present, make amends. The need for connection, because connection is king and connection heals. And lastly, learnings from both the studies, and I'm going to only look at those that I haven't really looked at earlier. I think what I will focus on is more where there were differences in the study on near-death experience and the study with HIV-positive women. Let's look at the second bullet point there about the fragility of life and the appreciation of life. This was more marked amongst those that had the near-death experience for obvious reasons. Their encounter with death was a lot more real than the experience of HIV-positive women who feared death and who felt damned, who felt that they had no future. And then, of course, the big difference in both these studies was that with the near-death experience study, there was no further fear of death because of their experience of this positive phenomenon, the light, the tunnel at the end, being greeted by relatives, etc., etc. Whereas in the study with HIV-positive women, there was still a great deal of fear of death. But in both the studies, that experience, that encounter, whether it was a near-death experience or receiving a positive diagnosis, helped them touch, reach out, and get their inner strength to come to the fore. Valuing their intuition, suddenly in the case of the patients who had near-death experience, they believed that because of their experience, because of this powerful experience, they could respect their own intuition and feelings more. They didn't always have to depend on others to tell them how to make meaning, how to make sense of their lives. And on that note, I will end, but not to leave you with nothing. I want you to help me now, and I want you to not only comment on any areas that you would like clarity on, where I could perhaps answer your questions, but I'd like some of you to contribute to any recommendations that you feel these studies could point towards in terms of therapy and teaching. And we have 11 minutes for that.